Hi, and good afternoon, everyone. You're very welcome to this webinar from Endo-ERN. Apologies for the delay. This certainly is going to be a webinar worth waiting for, and thank you for staying on the line as we begin. My name is Amy Casey, and I'm the Communications Manager for Endo-ERN, and I would first of all like to thank our speakers for organizing this webinar, making themselves and their expertise available to share with you today. Just a little bit of housekeeping before we begin. We have quite a number of presentations, and I'm sure that there will be questions. If I could invite you to put them into the chat as we go through the presentations, or wait until the end. We're going to have the Q&A at the end, and raise your hand if you would like to ask the expert directly, and I will unmute you and you'll be able to ask your question. So without further ado, I would like to hand over to our chair people for today. Dr. Julienne Léger is actually the chair of our MTG Group 8, and she is based at a member group in France. And Dr. Hanneke van Santen, who is based here in the Netherlands, will introduce our very first speaker. Over to you, Dr. van Santen, and thank you.
Thank you so much, Emma, and thank you so much for offering this opportunity to organize this excellent webinar. And I'm so happy to be able to co-host this together with my colleague, Julienne Léger. And I'm very happy to introduce the first speaker. So Dr. Clement is a very experienced researcher. She's a pediatrician, and she's also a postdoctoral fellow at the University of Utrecht at the Department of Pediatric Endocrinology. And she did her thesis in Amsterdam at the University of Amsterdam on the endocrine side effects of childhood cancer. And as you well know, maybe thyroid nodules and thyroid cancer are one of the very important endocrine late effects. So this is where she began her expertise on how we should screen, or if we should screen, for thyroid nodules in children who've been irradiated. And this is where she started her work in the thyroid cancer field. Currently, Dr. Clement is the coordinator of the European Eureka-based registry for differentiated thyroid cancer. So we are very honored that you will hold your lecture today for us on the epidemiology, risk factors, and classification of pediatric thyroid nodules. Please, Dr. Clement.
Good afternoon, and thank you, Hanneke, for the introduction. And in the upcoming 15 minutes, I will tell you something about the epidemiology, the risk factors, and the classification of pediatric thyroid nodules. Thyroid nodules are common in the adult population, but in childhood they are relatively rarely diagnosed. And ultrasound studies indicate that up to 2% of the children have thyroid nodules. The prevalence of thyroid nodules in children is lower than in adults, as you can see over here. But although thyroid nodules are less common in children, they are associated with a higher rate of malignancy, which you can see over here in children compared to adults. Thyroid cancer is the most common pediatric endocrine cancer, and thyroid cancer accounts for approximately 4% of all pediatric cancer diagnoses. The incidence of thyroid cancer in children is increasing worldwide, and this was clearly illustrated in a large registry study performed in the United States with data of the SEER database. And in this cross-sectional study, with a total number of 1,806 pediatric patients were diagnosed with thyroid cancer between 1973 and 2013. And the annual incidence was 0.48 cases per 100,000 person years in 1973, and increased to 1.14 cases per 100,000 in 2013. And as you can see, the annual percent change rose gradually between 1973 and 2006, and there was a sharp increase between 2006 and 2013. And this increase appears to be a result of both enhanced detection and a true increase in the incidence of thyroid cancer in children. Thyroid nodules are more common in adolescents and in younger children, and are more frequently diagnosed in females. And a survey of the Fukushima health management of nearly 300,000 children around Fukushima, intended to document the baseline rate of nodules on thyroid ultrasound around the time of the Fukushima nuclear accident in 2011. And in this study, the age and sex distribution of thyroid ultrasound findings were also analyzed. And as you can see, the total detection rate of thyroid nodules was 1% in males and 1.7% in females. In this first graph, you can see the difference in thyroid nodule incidence between males, which are blue, and the female patients, which are orange. And as you can see, below the age of 10, there's no difference, no clear sex difference in the detection rate of thyroid nodules, but there is after the age of 10, so after the onset of puberty. The investigators also analyzed tumor size in relation to sex, so these are in blue the males again, and orange the females, and they separated in different age groups. And as you can see, both in the male patients and the female patients, the incidence of thyroid nodules smaller than 5 millimeter are predominant in the younger children, whereas the nodules between the 5 and the 10 millimeter were more predominant in the other age groups. And this study also looked into the median size of the thyroid nodules, and you can see that the size of the nodule gradually increases with age. And lastly, they analyzed in this study the detection rate of nodules diagnosed as malignant or suspected for malignancy. And as you can see, that there are rarely malignancies seen below the age of 10. And there was an increase in detection rate after the age of 10 in both sexes. Besides age and gender, there are several other risk factors for the development of thyroid nodules and thyroid cancer, including iodine deficiency, the exposure to radiation, autoimmune thyroiditis such as Hashimoto and Graves' disease, prior non-thyroid malignancy, the family history of thyroid nodules and cancer, and genetic predisposition syndromes. Most cases are related. It's important to mention that ionizing radiation is the most common non-genetic risk factor for thyroid cancer in children. And most cases are related to exposure to external irradiation for treatment of primary other malignancies, and whereas other cases are related to exposure due to nuclear accidents. And the risk of thyroid cancer following thyroid irradiation is dose-dependent and age-dependent. And Sigurdsen and colleagues analyzed in 2005 in a nested case control study in 5 years of childhood cancer, the risk of thyroid cancer after certain doses of radiotherapy. And as you can see, the risk of thyroid cancer increases with radiation dose up to 20 to 30 gray, and at doses greater than 30 gray, there's a fall in the dose response relation. And this is possibly because higher doses induce cell death rather than somatic mutations. Furthermore, in this graph, their results demonstrated that young children, so children below the age of 10, are far more susceptible to the carcinogenic effects of irradiation compared to older children. Another study performed in a large cohort of 5-year childhood cancer survivors analyzed the effects of gender, radiation dose, and chemotherapy on occurrence of thyroid carcinoma. And the cumulative incidence of thyroid cancer was higher in females. As you can see over here, it was 1.3% compared to 0.6% in males. Also here you can see in this graph that patients, that the incidence of thyroid cancer is highest in patients who were treated with a radiation dose of 20 to 30 gray compared to other doses. And in this last graph, they also analyzed the effects of treatment. And here you can see that patients who were treated with both radiotherapy and chemotherapy, and then especially alkylated agents, increased thyroid cancer risks. And this is important to mention that it was only seen in patients with doses treated lower than 20 gray, in which cell sparing likely predominates over cell killing. Furthermore, you can see in these graphs that the latency time of thyroid cancer is long, with a low number of patients developing thyroid cancer in the first 5 years after treatment for their primary tumor or malignancy. Well, then something about a genetic predisposition. There are actually several genetic syndromes associated with the occurrence of thyroid nodules and progression to differentiated thyroid cancer. And you can see these syndromes are all associated with the occurrence of differentiated thyroid carcinoma. Medullary thyroid cancer accounts for approximately 5% of thyroid cancer cases in children, and usually arises in the setting of multiple endocrine neoplasia, so the MEN2A or the MEN2B. And for pediatric patients without medullary thyroid carcinoma, but with a high risk for the development of medullary thyroid carcinoma because of a red gene mutation, prophylactic total thyroidectomy is recommended during infancy or early childhood. And the recommended age of prophylactic thyroidectomy in asymptomatic red gene positive infants or children is based on the risk level, which correlates with the specific red mutation that they have. Then something about screening for patients with risk factors for differentiated thyroid carcinoma. So as I previously told you, children with a history of exposure to neck irradiation and a positive family history for thyroid cancer or known to have a thyroid cancer predisposition syndrome may be considered at high risk of developing thyroid nodules and differentiated thyroid carcinoma. And when such children present with a thyroid nodule, the risk of the nodule being malignant is increased. And surveillance programs for these patients aim, of course, to identify thyroid nodules suspicious of DTC at an early stage, so that the overall morbidity and mortality can be decreased. But as with surveillance of general populations, the potential benefits of surveillance should, of course, outweigh any potential harm. And there are possible advantages of screening and also possible disadvantages of screening in this particular group. The advantage of surveillance of patients at risk is the detection of DTC at an earlier stage, which possibly reduces the extent of surgery and the amount of radioiodine, and with that, the morbidity. Furthermore, if no cancer is found in these patients during screening, patients can be reassured that they do not have cancer at that moment, and surveillance could maybe the intensity and frequency could maybe reduced in these patients, which may of course decrease the fear of cancer. But there are also possible disadvantages of screening, which include the uncertainty of the benefit of early treatment for differentiated thyroid cancer, especially since most DTCs can be cured. The false positive results leading to unnecessary interventions, the detection of small non-aggressive DTC, which would never have caused clinical problems and this may lead to overtreatment, and the false negative results of surveillance leading to inappropriate reassurance in these high-risk patients. Well, for this reason, the recent 2022 European guideline for pediatric thyroid nodules and DTC has recommended that patients with a high risk of developing DTC, so patients with a history of radiation exposure to the thyroid gland or predisposition syndrome, should of course be counseled for surveillance, but that the initiation of surveillance and a decision regarding which surveillance modality, so the neck palpation or thyroid ultrasound to use, should be the result of shared decision making between the physician and the high-risk patients. Then something about the classification of pediatric thyroid nodules. This can roughly be divided in 3 groups. So the non-neoplastic lesions, which you can find over here, the benign neoplasms, which you can find over here, and the malignant neoplasms, which of course include the primary carcinoma, but also lymphoma, and there can be metastasis from another site. It's important to mention that pediatric nodules are benign, because most pediatric nodules are benign and do not require treatment, but it's important to determine whether a thyroid nodule is benign or a malignant. To do that, you need a rough clinical evaluation with diagnostic assessments that can include the thyroid ultrasound, but also function tests, scintigraphy, and a fine needle biopsy. Chantal Lebbink will discuss this flowchart in more detail later this afternoon. So this brings me to the key points of this presentation, which are that thyroid nodules are rare among children. Thyroid nodules in children are more likely to be malignant compared with nodules in adults. There are several risk factors for the development of thyroid nodules and differentiated thyroid carcinoma. Patients with a high risk of developing differentiated thyroid carcinoma should be counseled for surveillance, and initiation of surveillance and modality should be the result of shared decision making. And it's important that the rough clinical evaluation of suspected thyroid nodules is mandatory and, of course, important. This was my presentation. I would like to thank you for your attention.
Thank you very much. The questions being at the end of the webinar. So keep your questions for the end of this webinar. And we can now start with the second speaker, which is Dr. Lebbink. Is she here now? Yeah? Okay, thank you. So Chantal Lebbink is a pediatric endocrinologist in Wilhelmina Children's Hospital in the Netherlands. She's an expert on pediatric thyroid carcinoma and oncology treatments. And she's the first author of the European Thyroid Association guidelines for the management of pediatric thyroid nodules and differentiated thyroid carcinoma, which is recently published. So her talk will be on why is the workup of the pediatric nodule different than the adult nodules and its differentiations of thyroid cancer. So thank you, Dr. Lebbink.
Well, thank you for the introduction. I'm so sorry, my camera is not working, so I only have the microphone. In the next couple of minutes, I will talk about the diagnostic workup of pediatric thyroid nodules. Next slide, please. Thank you. Well, first, it's important to know, as Sarah already told, that in adults, asymptomatic small thyroid nodules are very common and increasing with age and are often found incidentally. and the majority of these remain asymptomatic for the rest of their lives. However, the prevalence of thyroid nodules in children is much less common and varies between 0.6 and 2%. Next slide, please. In the workup of thyroid nodules, the main question is how to discover the malignant nodule while avoiding overdiagnosis and overtreatment. And to answer this question, it's important to realize that the risk of malignancy depends on the population and the used screening method, so either by palpation or ultrasound. And for example, in 2013, a research group from Boston reported that in a time span of 14 years, 334 children were referred for suspected new nodules detected by palpation or as an incidental radiographic finding. And of these children, 125 children had one or more nodules with a diameter more than 1 centimeter. And the diameter of one of more centimeter was used as indication for a fine needle biopsy, which resulted in a malignancy rate of 22% with a median diameter of the malignant nodule of 2.9 centimeter. On the other hand, after the earthquake in 2011 in Japan, one of the nuclear facilities in Fukushima lost backup power and 3 cores melted down. And since then, a national screening program for thyroid nodules has been set up. Until 2016, 2,108 children with thyroid nodules were further examined. Next slide, please. A malignancy rate of 2% was found with a much smaller mean diameter compared to the results of Boston. Next slide. What we learned from this is that if more ultrasounds are made, more nodules will be found and they will less likely to be malignant. Next slide, please. In the ETA guidelines, we developed a diagnostic algorithm trying to discover the malignant nodule while avoiding overdiagnosis and overtreatment. And the first step in diagnostics is to confirm that the thyroid nodule is indeed a thyroid nodule and not a cyst or something else, as Sarah already told us. Therefore, a neck ultrasound should be performed as first step. Next slide, please. The 2 gatekeepers in the process of diagnostics are neck ultrasound performed by an experienced professional and fine needle biopsy. First, with a neck ultrasound, the risk of cancer in a thyroid nodule can be assessed based on multiple ultrasound characteristics. And for example, characteristics as hypoechogenicity, calcifications, taller than white shapes, irregular margins, and increased vascularization may increase the likelihood of a nodule being malignant. However, ultrasound alone cannot distinguish between a thyroid nodule and thyroid cancer. And for this reason, in suspect thyroid nodules, fine needle biopsy is always recommended. Next slide, please. Well, there are several ultrasound scoring systems to help stratify for which nodules fine needle biopsy is indicated. However, these scoring systems are based on adult populations and have not been validated in children. Dr. Tuli will tell us more about the diagnostic performance of adult-based ultrasound risk stratification systems in pediatric thyroid nodules. Next slide, please. For children presenting with a thyroid nodule who have a family history of medullary thyroid cancer or other MEN2A or MEN2B associated conditions, calcitonin measurement is advised, since medullary thyroid cancer of more than 1 centimeter will cause severe elevation of calcitonin. A low level of calcitonin in a thyroid nodule of more than 1 centimeter will exclude medullary thyroid cancer. However, no clear evidence exists on the potential benefit of measuring calcitonin on a routine basis in children presenting with the thyroid nodule. Therefore, the decision of measuring calcitonin in a child presenting with the thyroid nodule is based on individual conditions and the preference of the physician. Next slide, please. But how do we determine the malignancy risk? Well, the malignancy risk is not only based on a combination of neck ultrasound characteristics, but also on the presence of a history of radiation and signs of predisposition syndrome. And if there is a suspicion of the thyroid nodule being malignant, fine needle biopsy should be performed. Next slide, please. Molecular testing in fine needle biopsy specimen is a subject of debate, and the evidence for the benefit of molecular testing in thyroid nodules in terms of clear clinical implications is limited. However, this is a rapidly changing field. Molecular alterations are found in more than 75% of pediatric DTC. However, molecular alterations in pediatric DTC differ from those in adults. And in pediatric PTC, BRAF mutations are less common found compared to adults. But BRAF mutations have not been found in benign thyroid lesions. So for this reason, molecular analysis of BRAF mutation in an FMB specimen classified as Bethesda 5 could be helpful for the diagnosis of PTC. And in case where a BRAF mutation is found, the risk of a thyroid nodule being malignant is high, but needs to be confirmed, for example, by frozen section during surgery. And analysis of the presence of other oncogenic drivers and gene fusions, such as red PTC or NTRK fusions, may be considered in case of Bethesda 3, 4, or 5. However, the current evidence is not sufficient to incorporate this as a standard of care for all children with thyroid nodules suspicious for DTV. But the analysis of these oncogenic drivers and gene fusions could be performed in a research setting. Next slide, please. For benign thyroid lesions, so thyroid cysts or nodules with Bethesda 2 on FMB, follow-up is recommended with ultrasound after 6 to 12 months. And for a stable lesion, subsequent ultrasound follow-up is recommended every 1 or 2 years for at least 5 years. And when there is a significant change in palpable or ultrasound characteristics, repeated FMB should be considered. And when benign thyroid nodules cause clinical symptoms as compression or have cosmetic concerns, surgery may be the preferred choice of treatment. In children, tumors of uncertain potential of malignancy are diagnosed through FMB in up to 35%. And if FMB of the thyroid nodules shows indifferent results, so Bethesda 3 or 4, repeated FMB is suggested after 6 months. And if FMB is again indifferent, it is suggested to discuss about a patient in a multidisciplinary board meeting to find out a subsequent diagnostic approach. Next slide, please. I won't go too much into detail on the treatment of pediatric DTC, but the main message here is that in the majority of cases, pediatric thyroid cancer presents with locally advanced disease and lymph node metastasis, which of course impacts surgical approach. And therefore, total thyroidectomy is recommended as treatment for almost all children with DTC, followed by treatment with radioactive iodine. In pediatric patients with incidentally found very small thyroid carcinoma with non-aggressive histological features, hemithyroidectomy may be considered as a therapeutic option. Next slide, please. I would like to end with some take-home messages regarding the diagnostic workup. First of all, the risk of pediatric thyroid nodules being malignant is much higher compared to adults. And the two gatekeepers in the diagnostics are neck ultrasound performed by experienced professional and fine needle biopsy. Then the malignancy rate of thyroid nodules is not only based on a combination of neck ultrasound characteristics, but also on the history of radiation and signs of a predisposition syndrome. And then the evidence for the benefit of molecular testing in thyroid nodules in terms of clear clinical implications is limited at the moment. However, this is a rapidly changing field, and I believe that molecular testing will definitely become more important in the future. And last but not least, but follow-up and treatment depends, of course, on the results of FMB and the clinical symptoms. Well, thank you.
Thank you so much, Dr. Lebbink, for your excellent talk, and great that you could be here despite your camera problems. And I think this is a very nice bridge for our next talk. We will do the questions afterwards. Because as Dr. Lebbink has stated, ultrasound is very essential in its differential diagnosis, requiring a professional, experienced thyroid ultrasonographer. And Dr. Tuli is a pediatric endocrinologist at the University of Milan in Italy. And he's a very active researcher in the pediatric endocrine field with papers on diabetic insipidus, bone growth, and thyroid. And one of the most interesting papers is that one in 2022, in which you described the efficacy of the EU TIRADS compared to the ACR TIRADS in the risk stratification of thyroid nodules. So we are so happy that you are here to present this to us. And thank you so much, Dr. Tuli. Oh, I cannot hear you.
Can you hear me?
Yes, great.
Okay. Thank you for the presentation and the invitation in this interesting webinar. We'll see the diagnostic performance of the risk stratification systems based on adult experience in pediatric thyroid nodules. The main tool we have for the diagnosis of thyroid nodules is obviously the ultrasound evaluation, which is superior to palpation, especially for nodules with diameter inferior of 2 centimeters. We have seen that the prevalence and the incidence of thyroid nodules is increasing in the last years. And this is happening especially for the performing of ultrasound in specific populations, such as cancer survivors, especially those who receive radio treatment in the head and neck region, or that perform chemotherapies with that increase the risk of developing DTC. Another population that have specific protocols for DTC surveillance are patients with DICER1 mutation, PTEN mutation, or patients with McCune-Albright syndrome, as well as patients that have underlying thyroid disease, such as congenital hypothyroidism, Hashimoto thyroiditis, or Graves' disease. The main suspicious ultrasound features that may induce to perform the diago biopsy is the dimensions, the presence of nodules with a diameter higher than 1 centimeter. That is a cutoff taken from adult experience without taking into account that thyroid dimensions are very different among pediatric patients and adults. Other suspicious ultrasound features are the hypoechogenicity presence, the intralesional calcifications and vascularization, and the lymph node involvement. Other features that are not so present in pediatric age is the taller than wide shape and obviously the irregular margin. Being based on this ultrasound features, we have an increasing risk of malignancy as high the solid component of the nodule is present. So when a nodule is very cystic or with the most part of the nodule being occupied by the cystic lesion, the suspicious for malignancy is low, the higher is the solid component, the higher is the risk for malignancy. Being based on this, the American Thyroid Association, the American College of Radiology, and the European Thyroid Association have produced some recommendations to being based on the ultrasound future and the nodule dimension to perform whether to perform the AGO biopsy or not. The American Thyroid Association recommendations are based on ultrasound futures. Again, the cystic component is the main future that lead to a benign lesion. The hypoechogenicity, the solid component of the node, and macrocalcifications are the futures that lead to perform AGO biopsy. The same by the TIRADS that were built by the American College of Radiology. They give a score on the basis of the composition, the echogenicity, the shape, margins, and echogenic focus. On the basis of this score and of the dimensions of the nodule, there's the decision to perform the AGO biopsy or not. There is a very specific sonographic lexicon for all of these items, all of these issues, for composition, for echogenicity, for shape, margin, and echogenic focus. A similar effort was made from the European Thyroid Association that again, being based on the main ultrasound future suspicious for malignancy, give benign, low risk, intermediate, and high risk to the nodule, and then again on the basis of the dimension, there's the decision to perform the AGO biopsy or not. These scores are all built by adult endocrinologists and experienced on this population. But the size, how the size matter. We should consider that children have smaller thyroid than adults. These risk stratification systems are not validated in pediatric age, and we should obviously consider the intraoperator variability. There are some ultrasound challenges, especially in the distinction of anechoic and hypoechoic component of the nodule. Often in pediatric age, microcalcification are associated to benign lesions such as lymph nodes, such as thymus, such as Hashimoto's thyroiditis. And the difficulties in the nodules with mixed composition to determine which is the percentage of the solid and of the cystic component. In pediatric age, there have been some reviews and meta-analysis to determine what was the pooled sensitivity and specificity of the three main risk stratification systems based on ultrasound futures, the ATA, the U, and the ACR TIRADS. All of them have a sensitivity and a specificity in pediatric age that do not permit their use as they are, these scores as they are, and the same dimensions that are used in adults. The main issue is how many malignancy diagnoses do we miss by using exclusively these risk stratification scores, and the percentage is very high. The same was confirmed in our cohort, where ACR TIRADS did not diagnose 6 on 27 malignancies, and the EU TIRADS 7 on 26 malignancies, and we can not use only these risk stratification systems in their actual version for pediatric age. So what can we do? Probably we should consider other features that are not just ultrasound features. The demographic features are maybe should be considered. DTC is more common in females, but is more aggressive in males and in younger patients, especially under 10 years, as we have seen already previously in the previous presentation. Also, clinical features are very important. The underlying thyroid disease, we've seen that is a risk factor for all of the diseases: congenital hypothyroidism, Hashimoto thyroiditis, and Graves' disease. Cancer survivor patients, again, are at higher risk for malignancy, especially those who received radio treatment in the head and neck region, those who received radioactive contrast agents for a long time, and patients that receive chemotherapeutic agents and immunomodulators. Another risk factor is the nodule dimensions increase under thyroxine treatment. Again, some biochemical features have been related to a higher risk for malignancy, such as TSH level. We've seen that TSH levels upper than the 75 percentile is related to higher risk of malignancy, such as thyroglobulin level. Again, genetics, mutations predisposing to nodular disease or to DTC, such as RET, P10, DICER1, and GNAS, may be considered in a score that do not consider just the ultrasound features. So what do we need in the actual condition? Probably we need the PED TIRADS in order to avoid the unnecessary biopsies, but without missing malignancy diagnosis. So probably non-sonographic features should be considered in pediatric age, and a multi-expert panel is needed to build this course and to consider many features that are not just ultrasound. So they can be the gender, considering males at higher risk, the age, considering at higher risk the age under 10 years, the underlying presence of thyroid disease, the previous story of ionizing radiations and the drugs increasing DTC risk. TSH levels may be considered. In this case, should be discussed if higher than normal, or consider the 75th percentile. And the genetics, when RET mutation is present, it should be a direct indication for allobiopsy performing, rather than the presence of DICER1, P10, GNAS, or the presence of no mutation. Other ultrasound features maybe should be considered that are not present in the actual risk stratification score, such as the presence of solitary nodule rather than multiple, the localization in the right lobe, the lymph node involvement, and the intranodal vascularization. Thank you.
Thank you very much, Dr. Tuli, for your very nice expertise in ultrasound in children. We now move to the next speaker, which is Professor Fabio Pagni. Professor Fabio Pagni is Associate Professor of Pathology and Director of a Residency Program in Pathology in Milan, Italy. He is an experimental pathologist and an expert in proteomics and NGS to detect new diagnosis approach to thyroid tumors. So, Dr. Pagni will speak about the cyto-molecular landscape of thyroid nodules in pediatrics.
Thank you for the invitation and the possibility to give you some updating on the possible application of molecular techniques in the routine of the pathology lab for the diagnosis of cytological samples, mainly cytological, not only cytological samples, but also histological one, but mainly cytological. We know from the histological traditional perspective that the two most important categories for thyroid cancer are differentiated thyroid carcinoma and differentiated thyroid carcinoma. And the different molecular landscape of the genetic mutation regard both these two categories, both differentiated thyroid cancer and differentiated thyroid cancer, and the very different possible molecular alteration regard papillary thyroid carcinoma, for instance, and follicular thyroid carcinoma. We have some important and peculiar differences which have clinical consequences for pediatric patients too. We know from the epidemiology landscape that in the next year we saw a significant increasing in papillary thyroid carcinoma and not in follicular thyroid carcinoma in pediatric population, not only in microcarcinoma diagnosis in very small nodules, but also in larger ones like more than 2.0 centimeter nodule. So probably a genetic contribution of much more than an eventual one may be the reason of this increasing diagnosis. We know that genetic information are related with ambiental one, such as radiation exposure, and together they are the reason of the final etiological background of thyroid cancers. And we know that the genetic syndromes like Pagni syndrome or DICER1 syndrome may be very relevant in the clinical scenario of pediatrics. So the main molecular pathways we should consider for etiology in thyroid cancers and in pediatrics too are related with MEP kinase pathway, with BRAF and RAS as the two most important genes. But cancerogenesis in pediatrics too is a multi-step process, and we know that other important checkpoint as RET or ALK and copy number alteration may be involved in the pathogenesis. So the complex molecular landscape of thyroid cancers in pediatrics is related with diagnostic consequences in FNA management and the possibility to use additional tools from genetics to improve our diagnosis. And as I told you before, near to the differentiated thyroid cancer, we know the so-called sequence from differentiated forms to aggressive anaplastic thyroid carcinoma, which are very, very rare in pediatrics. However, we know that additional mutation to traditional MEP kinase involvement are required to a final diagnosis of a poorly differentiated or anaplastic thyroid carcinoma. In pediatrics, some peculiar findings we should consider are related with the presence of lymph node and distant metastasis in a significant part of our patient. However, irrespectively of these characteristics, a better survival from a clinical point of view is considered. On the contrary, the genetic landscape is quite different due to the prevalence of alternative gene rearrangement, gene mutation, such as fusion, which should be considered differently from the adult population. So when we compare adult patients with children, we should divide point mutation from rearrangement and fusion, both for a cultural or biological perspective, but most importantly from a clinical and pathological management and point of view. And we know that in general, in pediatry, we have important prevalence of fusions, and this is very different from adult population, and less presence of BRAF mutation in our subgroups. Much over, when we compare different mutation types, such as single nucleotide variant, we can observe a less prevalence of RAS, isoform H, K, and NRAS in the pediatric population compared to adult one. And other rare genes like TRAC may be involved with fusion mechanism in a significant proportion, like up to 20% according to different from different literature paper. About single nucleotide variant, we should consider different gene from the adult population, and I would like to show you DICER1, which is very important for PTC diagnosis. Why? Which is, as our colleague has just remembered to us, is involved in different multinodular goiter syndrome with schwannomatosis and other one. And this is very interesting in the possible pathogenetic development of a multi-step process in which we start from multinodular goiter and we move to additional unknown genetic events to cancer. This is a very intriguing gene, which is haploinsufficient tumor suppressor gene with different possible pathogenetic mechanism in thyroid cancer involvement. It should be considered every time we apply, for instance, a diagnostic panel for child patient. We should include in our panel DICER1, which is very interesting and very much more important for children than adults. But the king of the story is, of course, rat. We know that rat is involved in different rearrangement, mainly breakpoint and translocation, which involve the transmembrane domain and the extracellular domain, but we know at the moment about 50 possible different variants of rat rearrangement in human cancer, in lung cancer, and in thyroid cancer for the adult population, and mainly in thyroid cancer for children. And we know that rat rearrangement are very peculiar in pediatric cases, being involved as partner, namely PTC3, which is different from adult one, in which we have more than 90% of cases in which a paracentric inversion involving PTC1 is the main cause of the rearrangement. And we know that the group of rat mutated cases are mainly of the BRAF W600E-like subgroup. Usually they are classic type, we are multifocal with possible lymph node metastasis, and we know that this is very important not only for prognostic perspective, but for diagnostic too. Why? Because the evaluation of possible rat rearrangement is included in the vast majority of our diagnostic genetic panels we use to improve the diagnosis of indeterminate thyroid nodules. We know that possible false positive results may come from Hashimoto thyroiditis. On the contrary, we should consider with very suspicion when in our patient with an indeterminate FNA result we find a RET gene mutation, because this is probably cancer, and should so our clinical management should change. In our center in the north of Italy, in Monza San Gerardo Hospital, we perform in a multidisciplinary team fine needle aspiration pediatrics patient, not with many difference from the adult population, with a great psychological involvement of the family and of the patient too, up to from 7 to 8 years old. We start to explain the technique, which is cost effective, which is safe, with no important pain for our patient. So we try to involve our little patients to show them the importance of the diagnosis, and they agree with the possible application of a cost-effective in which genetic a genetic tool, a genetic or molecular test is applied in a small percentage of cases of indeterminate type 3 cases to improve the diagnosis. And after 10 years from routine introduction in our practice of this kind of additional tests, we can say that a combined application of cytology to genetics is the best to improve the clinical management of thyroid nodules, however, with some limits related with the preparation, which can change center by center, and needs, for instance, digital pathology to save smears in case we don't use liquid-based preparation. So we know that the best approach is a combination of morphology and molecular testing, discussed together with endocrinologists, with our clinician, and with patient too. And now we should consider, when we apply a genetic test to the diagnosis of our little patient, that the different flow charts for the adult population compared to recommendation for pediatrics may change one country from another one, and in general, in our experience, fine needle aspiration is largely more applied in the children population than in adults. We should consider when we would like to choose a genetic test that the risk of malignancy is very different depending on the different class of the Bethesda or the British system for reporting thyroid diagnosis. We don't know the exact prevalence of peculiar class of risk, such as cystic nodules. So I can say to you that we choose to apply a real-time PCR-based molecular test in our routine practice for pediatrics, which is a mix of technical reason and cost. And now we apply 8 genes based real-time PCR test routinely in every indeterminate nodules to have a better overview of the genetic landscape. However, we should consider that many centers are changing their perspective and moving to NGS to have shorter cost and turnaround time compared to traditional single gene sequencer strategy, to study rare mutation and co-occurring alteration, and in our opinion, this third point is the most important, to evaluate rearrangement, such as RET rearrangement, which are very frequent in the pediatrics population. Why? Because we can apply RNA-based protocol, and now we have commercially available panel, both DNA-based and RNA-based, which may be very useful for the diagnosis of the rearrangement and fusion genes in particular. when we consider fusion, we should consider that depending on the age of our patient, the prevalence may change and they may be dramatically high in, for instance, less than 10 years patient for RET gene. So we need RNA-based panel for a best practice and management and a better application of a genetic tool to improve our diagnosis. And this is true also for NTRK gene. And we should consider that in general, fusion oncogenes are associated with a higher proportion of large tumors. So a very important subpopulation of patients, extrathyroid extension and lymph node or lung metastasis. So this is an important point. And so if we decide to obtain information from the genetic landscape of thyroid nodules in the pediatrics and apply a diagnostic panel, we should have a good RNA-based panel. And we know that at the moment, the NGS is the best practice in our laboratory workflow to obtain such information. And the conclusion of our review of the current complex cytomolecular landscape of thyroid nodules in pediatrics is resuming this cartoon, in which we consider the possible division of high-risk molecular profile, in which an indeterminate FNA was found to be related with RET and TRK or BRAF mutation. So the patient should undergo to a total thyroidectomy. On the contrary, low-risk molecular profile, which we include P10 or DCR1 or RAS mutation, in which a final multidisciplinary discussion is the best to obtain a good management of patient in terms of lobectomy or total thyroidectomy or follow-up, depending on the clinical presentation. And for the future, we should consider that other very important information may come from other omics, not only NGS, but for instance, proteomics and transcriptomics. And for the moment, they are only bedside, but we hope to move bedside to this possible application. For instance, my team is involved in a large network, Italian network, for the application of proteomics, in particular in multi-imaging, which is an in situ technique which combine the traditional morphology with the different protein expression directly in situ in tissue samples. So the possibility to overlap directly morphological information to functional proteic information may be an alternative and complementary approach to NGS to increase our knowledge of thyroid cancer. And finally, we should consider the possible add which comes from artificial intelligence, which is the next future of our routine practice and digital pathology workflow in our labs, to have another possible perspective of the issue and increase our precision medicine in that field. Thank you for the attention.
Oh, thank you very much for this wonderful talk. And I think there are some questions now. Can I start for the questions? You said, I think the first speaker said about the recommendation for hemithyroidectomy, for only lobectomy in very small thyroid cancer. Is it less than 1 centimeter, or is there a definition for the very small thyroid cancer? And Professor Pagni said that we have to also to add the result of the molecular testings. For example, you said that if there is a patient with a DICER1 mutation, it's very low profile. So is it, and the recommendations is to perform hemithyroidectomy? Is it independently of the size of a tumor, or we have also to consider the size of the tumor? This question is addressed to Dr. Lebbink and to Professor Pagni.
Well, thank you for the question. Oh, go ahead.
From my point of view, in Italy, in our routine practice, we discuss every genetic findings in a multidisciplinary team. So I can't give you a unique answer. So we, according to Italian guidelines, we consider less than 1 centimeter maximum diameter as microcarcinoma to not only according to the last WHO definition. However, from a clinical scenario, yes, and the possible finding of low-risk mutations such as RAS, for instance, in such a population in 5-3 nodules is not sufficient reason to move the patient to surgery. It should be discussed in the clinical scenario in our routine practice. Very different is a BRAF or RET or track mutation in the very same less than 1 centimeter nodule. This is our basically our local management.
I would like to add that I think that the size of less than 1 centimeter also depends on the age of the patient. So I think we can set a clear cutoff on 1 centimeter because it's also the age and other clinical symptoms that we should take into account with that.
Thank you.
There was a question in the chat also from Annette van den Elzen. What is your, I think this question is for Dr. Lebbink or Dr. Tuli. What is your advice upon screening P10 syndrome for thyroid nodules? Current advice is namely only physical examination of the thyroid and no ultrasound. Dr. Tuli, would you want to comment?
Yeah. Okay, I think P10 mutation patients should be exposed to periodic surveillance. There is a discussion if to start it at 7 or at 10 years old, because in some few cases are reported presence of nodules or DTC under this age. But I think that after 7 years old, at least the first ultrasound check should be at that age, and then periodically on the basis of the evaluation.
Great. Dr. Lebbink, would you want to comment also?
Yes, of course. Well, at least in the Netherlands, we discussed with a national expert team about this as well. And we came to the conclusion that for in the Netherlands, we will start screening from the age of 10 years onwards, because we did a literature search and then we saw that from that age, the incidence was more than 5%. So that's why we start from the age of 10 years onwards and then we advise to screen by palpation every year and do an ultrasound at least every 3 years.
Great, thank you. So maybe I had a question for Professor Pagni on the DICER1 mutation. So as you say, for multinodular goiters, we see that a lot, of course, girls 16, 17 years of age with a multinodular goiter. Should we check them all for DICER1? or what would be your advice?
DICER1 is an important topic because it's a complex genetics situation in which we can have a different molecular mechanism of involvement. Is a so-called haploinsufficient tumor suppressor gene with the loss of one allele leading to tumor progression, but loss of both alleles having an inhibitory effect for tumor development, implying that one intact allele is needed for cell survival. So we should consider in our panel, of course, single nucleotide variant for DICER1, which are more frequent for PTC diagnosis. So the minimum, in my opinion, should have a panel, should test the patient with a panel which include DICER1 single nucleotide mutation for PTC. However, we know that another possible mechanism of pathogenetic mechanism passing from multinodular goiter and move to follicular thyroid carcinoma are rearrangement. So we should have also optionally the possible study of fusion of DICER1 for follicular thyroid carcinoma. So the minimal requirement is to test the patient, in my opinion, for DICER1 mutation for PTC, and optionally also for fusion of DICER1 if we suspect a follicular thyroid carcinoma. And in multinodular goiter, we can have a sequence starting from a benign process to PTC or FTC, both together. So both the possibility are available.
Thank you. So do you think that the reported prevalence on DICER may be underestimation at the moment? Because I think many of us don't screen DICER1 in all.
Probably we have a down evaluation of the real prevalence in a sporadic mutation in general population of DICER1, which is very rare as germline mutation in syndromes, but maybe up to 10–15% of undetermined cases may find a DICER1 sporadic mutation in the pediatrics population. On the contrary, for adult one, less than 5% of cases we found a DICER1 mutation, mainly in the context of the multinodular goiter and not for unique nodule. However, in pediatrics, up to 15% maybe the current percentage according to different literature reviews.
So I think there's another question in the chat box from Alexandra Kropinska. If either parent has a papillary thyroid cancer, are there any indications for thyroid ultrasound screening in children? Dr. Tuli, perhaps this one is for you? Or otherwise, Dr. Clement?
So I didn't have the audio. I didn't listen to the question. Sorry, can you repeat?
Oh, if a parent has a papillary thyroid cancer, it's an indication to screen the child.
I don't think no. But if we have sporadic evaluation, ultrasound evaluation for nodule for any other reasons, and we find a thyroid nodule in a pediatric patient which have a familiarity for DTC, the management should be more aggressive. This should be should be by this way, but I don't think that we need particular screening for familiarity if we do not have a reason to do an ultrasound check.
Great, thank you. There's another one from Evelyn Gevers. What's the experience with type of thyroid nodules in P10 syndromes and their management? Do you find benign nodules, and what is your management then? Who would like to answer this one?
We have a cohort of P10 mutated patients, and I think that most all of them have thyroid disease, not nodular disease, but almost all of them have thyroid disease that can be autoimmune thyroiditis or isolated hyperthyroidopenia, or even thyroid nodules. 75% of them in our cohort have underlying thyroid involvement, but none of them had DTC. It was just one that had undetermined nodule, which was and a total thyroidectomy was performed, but it was a benign one. So we have no experience of DTC in P10 patients.
Okay. So those are the questions from the chat.
I don't see any hands raised, Dr. Van Santen. So.
Okay, great. So maybe just one more question on the ultrasound. Dr. Tuli, would you recommend where should the ultrasound be done? So it has to be an experienced radiologist. Does it have to be a thyroid team with adult expertise? Does it have to be a pediatric radiologist? Do doctors prefer? How should we advise on this?
I think it should be performed by a pediatric radiologist because there can be many traps that adults are not used to see every day. Such lymph nodes, pediatric lymph nodes are very different from adults. The intrathyroid presence is very difficult to be diagnosed by adult radiologists, and I think the pediatric radiologist is the best choice. The best choice maybe would be to be performed together with a pediatric endocrinologist.
Thank you.
Well, I think we can draw it to a close, Dr. Van Santen.
Sure. Maybe Dr. Léger, you want to do the finishing words?
Yes, thanks all the speakers. It's a very, very nice webinar. And a particular thanks for Anneke van Santen who organized this webinar. And thank you all.
Thank you so much.
Thank you.
Thank you to you all from Endo-ERN, and we look forward to seeing you at the next webinar.
Thank you.
Thank you. Bye-bye.
Thank you.